Okay, so while Elise is bringing her presentation up, I'd like to thank everybody for attending. I am Linda Casbeyer with the Illinois Department of Public Health. I'm with the Comprehensive Cancer Control Program. And along with me, my colleagues who assisted in preparing this webinar, I'd like to thank Sherry Ferran with the Division of Oral Health and Elise Dracos, who's also with the Illinois Comprehensive Cancer Control Program. So at this point, I'll turn it over to Elise, who will be our moderator for today.
Hello. Now I would like to introduce Dr. Mona Van Kerrigan for the welcome.
Good afternoon, everyone. I just wanted to offer a few welcome remarks about IDPH Oral Health section and introduce a little bit about HPV as we hear from our expert speakers. So IDPH Oral Health section establishes programs designed to assure that the people of Illinois have access to population-based interventions through organized community efforts. Oral health programs of focus are community water fluoridation, dental sealants, community needs assessments, craniofacial anomaly program, oral cancer prevention, surveillance, and workforce initiatives. Assessment, policy development, and assurance are key public health functions of our section programs. The goal is to drive interventions, develop partnerships, promote improved oral health, and support systems that translate to optimal oral health for all. Today, our topic of focus is oral cancer. Oral cancer can interfere with or limit normal mouth function, impact the ability to breathe, and lead to mortality. Leading factors of risk include the use of tobacco products, heavy alcohol use, exposure to human papillomavirus or HPV, ultraviolet light, and poor nutrition. There has actually been an increase in oropharyngeal cancers linked to HPV infection in both men and women. In Illinois, HPV-associated oropharyngeal cancer incidence is greatest in the rural male population at a rate of 10.6 per 100,000. When examined by racial and ethnic groups, the greatest incidence rate is in white, non-Hispanic males at a rate of 10.1 per 100,000. Since 2006, there has been a safe and effective vaccine that prevents and protects against HPV infection. IDPH Oral Health is excited to collaborate with IDPH Comprehensive Cancer Control Program and the expert presenters we have here today on this webinar. Together, we will learn about the current HPV policies and guidelines, as well as understanding the vaccination schedule and how oral health providers can help increase HPV vaccination rates in Illinois. Thank you so much for attending. Elise, I'll send it back over to you.
Thank you, Dr. Van Kerrigan. Here are the list of objectives for today's meeting. And then this is a list of the speakers for today. We will provide their bios in the chat box. And if you have any questions throughout the presentations, please enter them in the chat box.
Can I interrupt for just a second? I'm getting several messages of people not being able to get in because they need a registration link. Someone told me that it can be found in the email that they originally received, but whenever it copied onto their calendars, the registration link didn't copy over. So, and how we can help all these people that are having trouble getting in.
The only way to get in that I'm aware of is through the registration. So I will try to send out a message to everybody.
That would be a great idea. This particular person that's emailing me now said that they never even received a link. So I'm recommending that they just re-register.
Yes.
Thank you. Sorry about that.
No problem. Okay, Elise, go ahead.
We will also be collecting all the questions and send out a Q&A after the webinar to answer everybody's questions. Dr. Sharon Perlman is our first speaker today. And Dr. Sharon Perlman is a dentist and a member of the Council on Practice of the American Association of Public Health Dentistry and a representative to the National HPV Vaccination Roundtable. Sharon?
Sharon, if you're talking, we can't hear you. We also don't see your slides. Okay, I have you unmuted.
Great. Can you see the slides now?
Yes, I can. Thank you.
And just the slides, right?
Yeah.
Perfect. Well, thank you so much. Thank you, Linda, Elise, Dr. Van Canagan, and Sherry for your efforts in organizing this webinar and for the invitation to speak today. And I thank everyone for their interest in saving lives through HPV vaccination promotion and taking the time to be with us today. Our goal is to inform oral health professionals of their unique role in preventing cancer through conversations with their patients and members of the community. I'll discuss the logistics of doing so. Mr. Michael West will share his incredible cancer journey, and Mr. Christopher Morrow will share important details about the vaccine administration and helpful resources. The important message that we want to convey to you today is that every time you encounter a parent, a guardian, a grandparent, or a young adult, you have an opportunity to prevent future cancers. We're advocates for period disease and caries prevention. We should also be vocal advocates for cancer prevention. By the end of today's session, I hope each of you understand the impact of HPV-related cancer, know policy support and guidelines for HPV vaccinations, will learn and hopefully commit to taking key actions to prevent oropharyngeal cancer caused by HPV. So let's begin with an understanding of the HPV cancer impact as it relates to oral health. And to do so, we first need to know what HPV is. The human papillomavirus is a very common virus that spreads from skin to skin contact. 80% of individuals will get HPV at some point in their lives. It usually has no symptoms, so most people with it don't even know that they have it. Most cases of HPV go away on their own, but other cases can go on and cause cancer. The CDC has estimated the number of HPV-attributed cancers each year at about 36,000. By using the vaccine, we can prevent over 33,000 cases of cancer each year. Can you imagine 33,000 people spared the trauma of cancer treatment? The vaccine prevents 6 different kinds of cancer, and of these, HPV oropharyngeal cancer is now the most prevalent HPV-attributed cancer, surpassing cervical cancer. And in this case, it's no honor to be number 1. So why is this? After all, so many people associate HPV with cervical cancer. Well, the vaccine works, and our colleagues have done a tremendous job of promoting it. A milestone study in Sweden demonstrated widespread use of the HPV vaccine dramatically reduces the incidence of cervical cancer. In a study for over a decade of nearly 1.7 million women, the vaccine's efficacy was especially pronounced among girls vaccinated before the age of 17, for there was nearly a 90% reduction in cervical cancer incidence compared to the incidence in women who had not been vaccinated. Friends, we too can lower the incident rates. After all, it's much easier to prevent throat cancer than it is to treat it. This graphic also details the estimated annual number of cancer cases attributed to HPV by HPV type. Note that most are caused by HPV type 16 and 18, but there are a number of other culprits. The current version of the HPV vaccine protects against 9 different HPV types. Further unpacking the slide, note that about 30% of oropharyngeal cancers are HPV negative. So it's important that we do not imply the vaccine will eliminate all oropharyngeal cancer. And this slide distinguishes between HPV and non-HPV oropharyngeal cancer. And if there's any good news, note that those with HPV-attributed oropharyngeal cancer have a better prognosis. And we have the power of reducing the incidence through vaccination. As Dr. Van Canningen mentioned, oropharyngeal cancer affects both men and women, but the data here shows that men are significantly more affected. And when we look at the data and ethnicity or race for both types, we see that men of all backgrounds have higher rates of oropharyngeal cancer than women. White men are the most likely to develop oropharyngeal cancer, followed by Black men and American Indian Alaskan Native men. Unfortunately, Black men have only a 50% 5-year survival rate compared to about 67% of white men. Dental care during cancer treatment is vital, as indicated in the study. I direct you to the conclusion, which states, for patients with head and neck cancer, survival is significantly higher in those who receive recommended dental care compared to those who do not. So we are literally lifesavers. And although great minds hope to develop an effective screening test one day similar to the Pap smear, it's vital to understand that there is no recommended screening test at this time to find oropharyngeal precancers. Common symptoms are listed on the slide, but note that many people may not have any signs or symptoms. So remind patients that they need to be vigilant and follow up if they do experience signs and symptoms. Patients may present with a persistent sore throat or a neck mass they notice when they're shaving, and this is the symptom that cancer has spread to the nearby lymph nodes already. Let's refresh our understanding of the oral pharynx, which includes the soft palate, the uvula, the tonsils, and the base of the tongue. And it's the tonsils and the base of the tongue, highlighted here in purple, where there are the most common sites of HPV-associated cancer. And while easily visible on this graphic, it's certainly not when examining a patient in your dental chair. On the graphic at the left, take a look at the crypts on the bottom of the base of the tongue. Oral pharyngeal cancer loves to hide out there, and we generally don't have the equipment and ability to properly examine these crypts. While oral cancer is easier for us to see, oral pharyngeal cancer is not. The pandemic has negatively impacted so many aspects of health, including adolescent vaccination, especially when it comes to HPV. The support of dental professionals will assist in getting adolescent vaccination back on track and help increase the rates in the long run. So now that we have an understanding of why HPV infection is of concern, I'm going to highlight a few organizational policies supporting HPV vaccination. In 2020, the FDA approved adding head and neck cancer prevention to the vaccine indication. Older materials on the internet likely don't mention oral pharyngeal cancer. The American Dental Association announced an HPV policy statement in 2018 supporting the use and administration of the HPV vaccine, and the American Academy of Pediatric Dentistry revised their policy in 2020. The Prevent HPV Cancers Act recently passed the House of Representatives at the end of November and is now in the Senate Committee on Health, Education, Labor, and Pension. It will appropriate $25 million to increase efforts for HPV cancer promotion if it's approved. The Advisory Committee on Immunization Practices, or ACIP, a group of national experts, recently updated the recommendation to include shared clinical decision-making between a patient and their healthcare provider for adults ages 27 through 45. ACIP recommendations are voted on and used by the CDC, and insurance companies also routinely cover them, but it's important for individuals to check with their own policies to be sure they have coverage. And in 2020, the American Cancer Society updated their HPV vaccination guidelines. The three key components include vaccinating girls and boys, focusing on ages 9 through 12, with a big push for ages 9 and 10-year-olds. Vaccinating 13 to 26-year-olds as a second line of defense, recognizing the vaccine's effectiveness is proven to decrease as individuals become more exposed to HPV. And then they differed from the ACIP recommendations and recommended that vaccinating over the age of 26 doesn't demonstrate population level benefits. So to frame our thinking, there's on-time vaccination from ages 9 through 12. There's late vaccination from ages 13 and 14-year-olds. And then there's very late vaccination, which is for anyone 15 through 26. And these ages require 3 doses of the vaccine. We in the world of oral health can promote HPV vaccinations in a number of settings. Those who see children and provide general dental care or provide orthodontic care have seamless opportunities. But you can also promote this through community-based sealant programs, and don't limit it to just children. For example, when performing a head and neck examination on an older individual, promote the vaccine. It could save their grandchildren. When you perform your 9th grade school exams, don't miss the opportunity to verify that the child has received both doses, and if not, guide the parents on how their children can be fully vaccinated and why it's so important that they do. The big push to start HPV vaccination earlier makes sense. From a healthcare perspective, it's been shown to increase on-time completion rates. We're able to have the conversation during childhood, avoiding those uncomfortable conversations that mistakenly focus on sexual activity instead of cancer prevention. And from a parent perspective, studies demonstrate that they like that it decreases the number of immunizations that they need to get when a child is 12. COVID-19 interfered with the rollout of these new guidelines, and many may not be familiar with them. So let patients know that they're new based on the latest research, and take this opportunity to collaborate with your colleagues and share your newfound knowledge. Now, we know why HPV vaccination matters and policies from professional organizations supporting it. It's time we talk about your role and how we become the cancer prevention advocates that we need to be. Our framework for becoming cancer advocates comes from an action guide created for dental healthcare providers by the National HPV Vaccination Roundtable, which was founded by the CDC and American Cancer Society. I was honored to help develop this action guide, which was later co-branded by the American Dental Association. This action guide outlines 5 key action steps and links to valuable resources to use in daily practice. I encourage you to visit the resource library on hpvroundtable.org to download this and other very helpful HPV-related tools. The first action is to know your unique role. Although dental providers can't screen for HPV-related precancers, we can and we should reduce cancer by promoting vaccination. Our profession is more likely to see children as patients each year than pediatricians. According to the CDC, 86% of children ages 2 through 17 visit the dentist each year. And not every parent or guardian is convinced that they should vaccinate their child. Hearing the message from multiple professional sources on multiple occasions will increase the likelihood that they will follow up. And not only do oral health professionals see kids more frequently than physicians, 9% only visited a dentist, further justifying why our oropharyngeal cancer messaging is critical. To help your teams become educated on the links between HPV and cancer, we have several key tools and resources for you. And in the interest of time, I'm going to quickly pop them on the screen for your reference. Check out this 11-minute video training on the HPV Roundtable YouTube channel. And here's a handy infographic for the American Academy of Pediatrics and Survivor, a cancer survivor advocacy group. Here are 2 more key resources from the American Academy of Pediatrics. The second action step is implementation of cancer prevention in daily practice. Plan to prevent cancer. When discussing a treatment plan, sandwiching the new vaccine recommendation between well-known procedures will make it easier for parents to adopt. And when it comes to anticipatory guidance, provide the prevention schedule and reinforce it at future visits. When discussing the vaccine, recommend with conviction and lead with cancer prevention and not HPV. We're essentially rebranding this life-saving product as a cancer prevention vaccine. Patients will be moved to take action when you share your personal experiences. For example, I vaccinated my daughter and son, and as a parent, I can rest easy knowing my children have a reduced cancer risk. Or I see the tremendous pain my patients with head and neck cancer experience. I wish they had the chance to get the vaccine and not suffer so much. We're so fortunate we now have a vaccine that your child can have to prevent life-altering cancer. By channeling someone you know who's been affected by cancer, you'll deliver the messages with passion and convey why this is so important. But don't be dismissive or a know-it-all. There are so many false but convincing memes out there. Truly listen, repeat their concerns so they know they've heard it or you've heard it, and address it. And praise parents for wanting to do the best for their children. Hygiene appointments are optimal opportunities to have these conversations. You have extended time to deliver a monologue on the importance of vaccination. We have some good tools to help you with these conversations, but a tool is only useful when it's used. Team members need to actually practice sharing simple, clear messaging so they're comfortable speaking with parents. This tool is one of the many great resources from Team Maureen's Dental Provider Toolkit, which is free to download on their website. And check out CDC's tips for talking to parents. This cue card was developed by researchers at the University of North Carolina, Chapel Hill. You want this community to see and hear cancer prevention messaging. This can look like posters in your office and information on your website and social media pages. I encourage you to inquire about vaccines on your medical history form, which will serve as a great conversation starter. Emphasize that cancer prevention begins with the parent. They will need to take follow-up action to schedule the medical appointment necessary to protect their child. The ADA has a brochure for patients, which you may want to share, and the Illinois State Dental Society has recently convened a head and neck cancer task force, developing materials and continuing education to further advance knowledge on this important topic. The third action step is actively referring patients for HPV vaccination. After you speak with your parents and motivate them, you and your staff need to know where to send them. So refer patients to a pediatrician or family practice care provider, and if patients lack one, share your recommendation or encourage them to contact the local health department or community health center. Chris will provide more details on how to do this. Vaccine prescription pad reminders are helpful for patients to have something actionable and tangible to take with them, which you can customize for your own practice. And if you're at a federally qualified healthcare center or co-located with medical providers, coordinate both the medical and dental appointment. If you use electronic medical records, pre-program the information so the reminders will automatically trigger. And if you're providing screening at a health fair, focus on the follow-through and have resources available. Better yet, arrange colleagues to provide the vaccinations on site. Step 4 is to collaborate. It's one thing to refer to other healthcare providers, but by partnering with them, you can help ensure the continuity of care. And just as you refer to their medical home, they should refer patients to your dental home for quality oral health care. You may also want to engage in HPV cancer prevention efforts through a coalition. It's a great way to shine a light on your dental practice or program. The fifth and final step is engaging your full dental team. We need to create a culture of cancer prevention in the hearts and in the minds of all team members. Be the official HPV vaccination champion within your office and help ensure that the entire team, and not just providers, are on message about preventing cancers through vaccination. Even when people check out and schedule their next appointment, take the opportunity to reinforce the referrals. One note to keep in mind that I frequently see people who are confused about oral cancer, which is generally not prevented by the vaccine, and oral pharyngeal cancer. So make a point to clarify the distinction. I leave you with our call to action. Access and use the tools and resources. Share them with your colleagues and create a workplace culture where every parent, guardian, grandparent, and young adult receives the HPV vaccination recommendation. Each of us can help reduce the HPV cancer burden, and you have the power to make it happen. There's so much more that I'd like to share, so if you have questions or comments that haven't been answered, please reach out. Now, get your tissues ready as I hand it over to Elise, who will introduce Mr. Michael West.
Thank you, Dr. Perlman. Our next speaker is Michael West. Michael West is a lawyer with the Clark Hill Law Firm and a stage 4 throat cancer survivor.
Morning, everyone. Thank you so much for the opportunity to share my story. Just want to make sure you guys can hear me and see the slides. I always appreciate the opportunity to share my story and following up on Sharon's presentation. You know, you've heard the statistics and you understand that HPV is out there. And I like to share my story so that hopefully you can get a better understanding as to the devastating impact that an HPV-related cancer can have on someone's life. And not just them, but also affecting every aspect of their life, including their family. My journey into the cancer world started one regular Saturday morning when I was shaving. And I reached up and felt the left area of my neck, and I felt a little tiny bump. It felt like a little hard BB, like you'd shoot out of an old school BB gun. But I felt fine. I had no other symptoms at all. Everything in my life seemed to be going well. I was eating healthy, working out all the time. I'd never smoked. And I had every reason not to go to the doctor, but because I am a hypochondriac, thank God, I knew that that was in my lymph node area, and I just wanted to go to the doctor to get it checked out. So I went to the doctor, to primary care. Thank goodness he was up on HPV-related type symptoms. He immediately referred me to an ENT specialist. I underwent a CT scan as well. He stuck a very long needle into the side of my neck, and before I knew it, I was diagnosed with stage 4 squamous cell carcinoma of the throat due to HPV type 16. And what they told me was this knot that I felt in my lymph node area was actually the cancer that had spread, and they needed to try to find the primary source, which they suspected based on how these symptoms were presenting, were somewhere in my oropharyngeal area. So I then underwent a PET scan. I also had more ENT biopsies where they pulled out my tongue with basically a wash rag, gave me shots, and then carved off pieces of my tongue and my throat. Unfortunately, the primary source was not there. But then as I was going through this process, you wonder about your family. You can see my beautiful family there, and you're wondering, will I be able to get through this? I mean, once you hear stage 4, I thought my life was over. And then you're just trying to comprehend all that, and you're wondering if all these things that you're doing with your family, is it the last time? Will I be able to walk my daughter down the aisle one day in her wedding? Will my 4-year-old son even remember who I was? And so I ended up still trying to find this primary source, because until they find your primary source, they really can't treat you. And so I ended up undergoing surgery to remove tonsils, small parts of my tongue and my throat again. And unfortunately, they still could not find my primary source. But because they knew it was HPV type 16, they were confident that it was in my oropharyngeal area. So I ended up with a primary source unknown tagged on to the end of that long diagnosis I gave you a minute ago. And that's what made my particular journey a little more difficult than just a regular head and neck cancer, which is devastating in and of itself, because what it meant is they would not be able to spare any of my tissue as they went through the treatment. And I would get broad blasted with high intensity radiation over the entire course of my treatment. So my treatment was to consist of 3 large doses of cisplatin, kind of is known as a super chemo. These were 8-hour sessions. At the beginning, in the middle, and about 10 days before the last radiation treatment. And I was to receive high intensity radiation for 7 weeks, Monday through Friday, for a total of 35 treatments. I showed this screen just to give you a quick snapshot of the different specialists that are involved in your care. And I'm so thankful for each and every one of the many wonderful people in those different specialties who all came together on a part of my cancer team to get me through that journey, and not just get me through it, but to allow me to have a good quality of life on the other side. I also throw this screen up to just give you a snapshot of the many medications that I was on because of my particular diagnosis and particularly the intense pain that I was going to be enduring. You can see some pretty heavy hitters on there, from Dilaudid, fentanyl, gabapentin, all the way down. And despite being on those medications, the heaviest of them, probably about the last 2 weeks and then for about another month of that. I mean, there was never a moment when I was not in pain. Chemotherapy, obviously the traditional symptoms, nausea, vomiting, change of taste. I eventually lost my taste completely, fatigue, and I'll tell you about the sores here again in a second. And then the radiation was really difficult. That is a picture of my mask that I used every day. And what they do for head and neck cancer patients is that starts out as a flat screen. They heat it up, they form fit it to you. And then those black things you see around the side, those are screws. And you lay down on the table each session and they bolt you down because obviously it's very important you don't move. And they apply that radiation to you 15 to 20 minutes each session. And the radiation combined with the chemotherapy, it's very cumulative, it's very progressive, and it's quite painful. And I developed dry mouth as a result of many of my salivary glands being obliterated during the radiation process, difficulty swallowing, speaking, and lost my voice for at least a couple of weeks before they tailored my treatment a little bit, nasty skin burns. And I think the most difficult thing was probably the massive headaches towards the end when all the tissue was swelling up inside my skull area and it had nowhere to go. And that really caused some devastating headaches. But the most difficult thing was probably the sores. There were so many sores that developed coming up my mouth all the way through my throat, on my tongue, my gums, and those sores would open up. And those were incredibly difficult to deal with and made it very difficult to even swallow. I pretty much, it was excruciating to swallow at the end of my journey, even my own spit. I was given a peg tube, a feeding tube, which I used throughout my journey to try to keep me alive and be able to be healthy enough to get through the treatment. But even with that feeding tube, I had lost 70 pounds by the end of my journey. And it was a brutal journey. There's the 3 dates of the chemo sessions, but I finally did finish, and they let you ring that little bell, which seems silly when you first hear about it, but there's nothing more important to a cancer patient than basically ringing that thing off the wall when you finally cross that finish line. And you can see me there, obviously compared to that first picture, obviously in an emaciated condition. And within just a few hours of that picture, I wound up in the hospital in a completely decimated condition, immense pain. And I just couldn't picture how my life would ever be happy again. How would I ever feel good again and be able to move on? And just a quick story on the recovery. I think every person, when you go through whatever difficult journey there is in your life that you're facing, there's those pivotal moments where you can go dark or light. I never judge people who get stuck on the dark side and are just trying to get through to somehow be happy again. But my pivotal moment came when I got home from the hospital. I looked at my body in the mirror and I saw, I was just in a completely emaciated condition, feeding tube hanging out of me, and I felt terrible. And I said, what's the point? But very quickly, thank God, I reflected back to my friend being buried about a year earlier before I was diagnosed, leaving behind 3 kids. My mother-in-law, who was battling for her life with pancreatic cancer and a terminal diagnosis. And I very quickly realized the point was I was alive. I had made it. I had survived that treatment. And then everything was about trying to get back to a life, to be appreciative, to be thankful, and to enjoy every precious second and every day that I still had to be with my family, because I had the chance to get better when so many of my brothers and sisters were not given that chance. It was a very excruciating process. And people through that would always say, you're so strong. And I always appreciated that, but I never felt strong. I felt defeated and I felt weak. And I thought this quote right here pretty much sums up how I was feeling about never knowing how strong you are until being strong is the only choice that you have. And it's simply what you do to try to get alive. Thank God, after the radiation got out of my system in 90 days, I underwent a PET scan and I heard those beautiful words, no evidence of disease. I've just crossed the 4-year remission line. I've got to wait to hopefully get to 5 years before I get to hear that beautiful word cured, when I still get followed up with the various doctors. But I'm just enjoying and appreciating and loving every single day. And I don't have a lot of time today, but I don't want to skirt over the mental part of it. Obviously cancer is a very difficult thing to handle physically, but it also has a very significant emotional toll on one. This is a picture I took about a month after my news that I was in remission at my son's birthday party. I had every reason in the world to be happy, but inside I was still hurting. And you go from all these people taking care of you to suddenly being alone. You go from seeing your body in the active process of dying as they give you chemotherapy and radiation, and yet you're trying to then somehow get back to living a normal life. And also with all those drugs and the incredible fog that it puts in your mind, it's very, very difficult to get back to the proverbial normal life. And what I tell people is one of the strongest decisions I ever made was realizing that I needed help. I needed to talk to someone, and I did, to try to process those feelings and get back to somehow being able to appreciate every single day. Obviously, I have challenges in my recovery. For the dental community, there's obviously many because of the areas that were treated. I go to my dentist 4 times a year. I have to take extra fluoride to try to protect my teeth. And obviously, you know, you hear the horror stories as survivors that you never want to be in a situation where you lose your teeth and we have to go through terrible types of treatment in order to deal with that process. But, you know, it's not about any of the side effects that I have or anything like that, because this is a beautiful quote from my head and neck doctor. Whatever I can't do anymore, it's just simply the small price that I paid to still be alive. And what a small sacrifice when I look at my wife and my kids every day when I wake up and I'm still here and living this appreciation for every single precious day that we're given that is not guaranteed for any of us. And so my motivation now is not in any way about what cancer took away from me, but it's about what I do with my life with what I have left. And what I want to do is share my story, be an advocate, be out there, especially for HPV. As I was going through this, I had heard about HPV causing cervical cancer. My daughter had the vaccine, but I had no idea that it could cause any other cancer besides cervical. And I certainly didn't know that it could affect men. And so I want to get out there because I know there's got to be other people like me who just need that extra information. I also want to let people know that no matter what the journey is or challenge you're facing in your life, that you can overcome. I want to show people when they're going through this devastating treatment that by seeing me on the other end of it, although we're all different, there's no guarantees, it is possible to get through that horrific journey and to get back to a beautiful life and to engage in advocacy, to work with wonderful people like all of you who are now hopefully going to take this information and go out there and dealing with these statistics that you heard Sharon go through. It's just staggering how many people are going to come into contact with HPV, and trying to put them in a situation so that particularly for these next generations, we can hopefully knock out, if not potentially one day eliminate any HPV related cancers so that no one has to ever lose their life or go through this brutal journey that will change their life forever. And it's about information. And one that I really try to focus on with parents when I'm dealing with people and they talk about, well, this is a decision when it's that the kids are young, let's kick it down the road. The scary statistic is that virus can lie dormant in your body for up to 20 years before it turns into something ugly like cancer. And it's about exposure. Once your child is exposed to that particular virus that the vaccine could have prevented, then it's too late. And so when you talk about those from those particular facts, it really seems to resonate with parents about why it's so important, in addition to their immune systems being so capable and ready to process that vaccine, it's also about the exposure risk and protecting them before they engage in the activity that could expose them to that. And so these are my two beautiful kids. I know there's parents out there, obviously, who love their kids the way that I do. And, you know, just the odds are your kids will be exposed to HPV. You want them to be in marriages or partnerships. You want to have grandchildren one day. Why would you not protect them? And so don't flip the coin is what I tell parents, because if you don't get the vaccine for them, that's literally what you've done. You've flipped the coin with their life about whether or not their body is going to fight off that HPV virus when they inevitably come into contact with it. And so it's for those two groups, either those parents who are like me, who did not know and need that information, or those who are, for whatever reason, have made the affirmative choice to not have their child vaccinated. So hopefully hear my story, think about whether they would ever want their children to ever go through that or their family to go through that, and then hopefully go to the providers and have a more detailed, informed discussion that hopefully will lead them to a point where they will decide to get their child protected, because it is about cancer prevention. Thank you so much for the opportunity to share my story with you today. I wish you all the best on your continued journey through this beautiful life.
Thank you, Michael. Our final speaker is Christopher Morrow from the Division of Immunization at the Illinois Department of Public Health.
Good afternoon, everyone. I certainly want to thank Linda and her team for asking me to speak on this very, very important topic. And also just thank the previous speakers for everything that they have brought to this presentation. And a special kind of heartfelt thanks to Mike for sharing his journey as he kicked his cancer's butt. So keep on keeping on, Mike. For sure. So Just a couple of disclosures I need to make. I have no relevant financial relationships with the manufacturers of any commercial products and or providers of commercial services discussed within this activity. And I do not intend to discuss any unapproved or investigative uses of a commercial product or device in my presentation. By the end of this presentation, you should be able to list the CDC's, ACIP's recommended schedules, catch-up schedules, and ages for HPV vaccine, demonstrate at least 3 ways to improve HPV vaccination rates, and of course, use the Illinois Department of Public Health's Vaccine for Children Provider Search website to refer children through age 18 for HPV vaccines. So the current HPV at this time is the product Gardasil 9 by Merck. It is the only HPV product being distributed in the United States, and it is licensed for both males and females. As mentioned earlier by Dr. Perlman, of course, children and adults not aged 9 through 26. Catch-up vaccinations are typically not routinely recommended for all adults over the age of 26, but that would fall into the realm of shared clinical decision-making between the patient and the provider for ages 27 through 45. And a special note there at the bottom, Gardasil 9 is not licensed for adults more than 45 years of age. The current CDC ACIP HPV recommendations for children age 9 through 26 is definitely routine recommendation for 11 or 12 years of age, and as mentioned earlier, minimum age of 9 years. There is a catch-up recommendation for all persons through age 26 that have not been adequately vaccinated. So for the scheduling for the Gardasil 9, for those initiating vaccination prior to age 15, the recommended immunization schedule is just 2 doses of HPV vaccine on a 0 and 6 to 12 month schedule with a minimum interval of 5 calendar months. And note that if they start before their 15th birthday, there is no 3rd dose. But in the second bullet there, for those initiating vaccination on or after their 15th birthday, or for persons with certain immunocompromising conditions, the recommended immunization schedule is 3 doses, and that's on a 0, 1 to 2, and then a 6-month schedule. And the next slide will go into a little more detail on that. The second dose should be given 1 to 2 months after the first dose, and the third dose given 6 months after the first dose, with a minimum interval between the first and second doses of 4 weeks. The minimum interval between the second and third doses of vaccine is 12 weeks, and the minimum interval between the first and third doses is 5 calendar months. If the dose is administered more than 4 days prior to an age or an interval recommendation, then you would need to repeat the dose. If the vaccination series is interrupted, the series does not need to be restarted like most vaccines. 3 ways to improve HPV vaccination rates. Of course, has been discussed, oral health practitioner's recommendation. So clinician recommendation is the #1 reason parents decide to vaccinate, and it's especially important for HPV vaccination. To that end, CDC has a training module on how to make effective HPV vaccination recommendations, and there's a link on that screen. And then finally, to improve vaccination rates through the practitioner's recommendation, you can actually role play patient-provider scenarios to kind of help practice with some of the opportunities for education that you may hear from the parents. So that would be one way to improve HPV vaccination rates. Second one, consider bundling the HPV vaccine recommendation with other vaccines if you administer them, such as with meningitis or whooping cough. So what that might actually sound like is, now that Johnny is 11, he's due for vaccinations to help prevent against meningitis, HPV cancers, and whooping cough. We'll give those shots during today's visit. Do you have any questions about these vaccines? And so by placing HPV in the middle of the list of vaccines being offered, HPV is normalized, which increases acceptance and demonstrates the importance of HPV cancer prevention vaccine. A third and final opportunity to help improve vaccination rates. Use your local health departments or nearby vaccines for children clinics resources for children aged through 18. Referrals to the local health department or VFC clinic can assist you making sure your patients remain vaccinated against HPV-related cancers if carrying the HPV vaccine is not an option for your practice. And a special note here, for patients 19 and older, it's recommended that the patient checks with their primary care provider, their medical home, or the local health department, since the VFC program would not be able to assist those patients who have aged out of the VFC program. So on my next slide, we actually have the Illinois Department of Public Health's VFC provider search page. Again, this would be mainly for children through age 18. Clicking this link above will take us to a page with a map showing nearby VFC clinics based upon parameters entered. But it's important to note that the City of Chicago VFC clinics are not being shown on this map. They are separately funded. And so you'd want to reach out to the Chicago VFC program at chicagovfc@cityofchicago.org to help identify City of Chicago-based VFC providers. So in this example, in the box to the upper right, in the red box, I've entered the zip code or address of Springfield, Illinois, and then search within 5 miles. When I hit the search button, the little map on the left-hand side populates with those VFC clinics that are within that range of distance. And on the kind of below the red box is a listing of facilities, also those same facilities that are represented by the different colored pins on the map. So we see facility, location, whether or not they serve CHIP patients, and the distance as well as the direction in that list. So if you click or if you hover over each linked facility, it will show you directly where that location is on the map. And of course, under the direction column, click here, that will actually take you out to a Google map that will allow you to put in the beginning address, and then Google Maps would direct you or the patient, parent, guardian to the location of that particular provider. It's important to note in that display of providers, the CHIP column, yes or no. If a provider is listed as no, that means that they do not carry Children's Health Insurance Program or CHIP vaccines. Basically, a CHIP patient is a CHIP patient because his or her family has the financial wherewithal to be able to afford co-pays and so forth. So they are not considered as straight Medicaid patients. So if your patient is in that situation, then they may very well be CHIP, which is called Title 21. And if they are CHIP, then you would certainly want to, pay attention to this CHIP column to say yes. If you're trying to help arrange where they could contact to get VFC or CHIP vaccines. And of course, the map shows by the pins, the different color of pins, the type of provider that they are. So the green pin is private providers. The blue pins are public health sites, such as your local health departments. And then, of course, the orange pins, federally qualified health centers or rural health clinics. So a little more information below those PIN designations here shows in order for a child to be considered as VFC eligible, they must be under 18 years of age, 18 or younger, and at least one of the following criteria. So Medicaid eligible, uninsured, meaning they have no health insurance, American Indian, Alaska Native, or underinsured. So an example of that is right below where it says children who have health insurance that does not cover immunizations may receive those federally funded VFC vaccines only at the FQHCs or the RHCs. Or at a deputized local health department. They would need to contact one of those facilities to determine eligibility and, of course, make sure that they have the Gardasil in stock. Those providers listed shown in the map and listed here in this portion are providers that are actively enrolled in the VFC program and have agreed to be listed on the IDPH website. So definitely help the parents, patients, and guardians reach out to those locations, or at least provide that information to them if you're unable to assist them directly with HPV vaccination. List of sources here, of course. One of the best sources, I believe, is also at the very bottom, CDC's Epidemiology and Prevention of Vaccine Preventable Diseases. That's referred to as the Pink Book. It will go into a lot of detail about scheduling and so forth for vaccines, specifically HPV. So that's a great resource to have if you have additional questions about HPV vaccines. That's all I have. So I will thank you all for your time, and I will return to Elise.
Thank you, Chris. Actually, I will pick it up from here.
Okay.
So I would like to thank all of our wonderful speakers, Dr. Perlman, Mike West. Your story was very powerful, and it truly shows the importance of early detection when possible and vaccination just simply to prevent. And Chris Morrow, thank you for going over the vaccine schedule. So on behalf of my colleagues, Sherry Ferran from the Division of Oral Health, Elise Dracos with me in Comprehensive Cancer, and Dr. Mona Van Canagan, we appreciate your attendance in today's webinar to learn more about HPV vaccination and the oral pharyngeal cancers. So we will send out the presentations after the webinar, and there is a couple of requests to specifically have the list of the resources listed. So we will prepare that and email that out also. We had a couple of questions in the chat box. There is one issue, Dr. Perlman. Let me get back to the question. Someone pointed out, if you can just reiterate, important point about the difference between oral cancer and oral pharyngeal cancer and what the vaccine won't prevent. If you could just summarize it just to reinforce that point. You're muted, Dr. Perlman.
I truly appreciate that comment, and I can't emphasize it enough. People confuse the two. The vaccine only will focus specifically on oral pharyngeal cancer. Oral pharyngeal cancer is much more difficult to diagnose by a dentist. Many people confuse the two, and we have to be clear when we communicate about oral cancer and oral pharyngeal cancers, and not imply if we're doing a head and neck exam, because we don't want to mislead a patient in believing that because they've had that examination, they're not at risk. They're two distinctive diseases, and we have to keep that in mind. So thank you for picking up on that.
Okay. Well, thank you to everybody for attending. And like I said at the beginning of the webinar, we are recording the webinar, and we will make this link available to everybody. So again, thank you for attending and have a great day.
Thank you.